Hello, my name is Damian Christian. I am the Strategic Alliances Specialist with the Men's Health Network. The Men's Health Network is a national nonprofit organization whose mission is to reach men, boys, and their families where they live, work, play, and pray with health awareness and disease prevention messages and tools, screenings, educational materials, advocacy opportunities, and patient navigation. We have spent many years working with the bipartisan Congressional Men's Health Caucus, co-chaired by Donald Payne Jr. from New Jersey and Mark Wayne Mullins from Oklahoma. We love their participation and their collaboration with this effort. Without them and their effort, this briefing and many others would not be possible. I also want to let you know, if either of the congressmen stops by, we're going to pause our briefing and let them speak for a few minutes, and then we'll continue. We are honored to have you in attendance today to this briefing on opioids and how it affects men in the workplace. As most of you know, this epidemic has had a ravaging effect on this country, but particularly men who are in working environments. We're going to have a full panel of speakers who are going to present unique insight and expertise into this very dire and very important subject. But first, our first speaker and presenter is Dr. John Bonhomme. Dr. John Bonhomme is on the board of directors for the Men's Health Network. He's the founder and president of the National Black Men's Health Network. He's a board-certified public health and general preventive doctor. From 2003 to the present, he has served as the corporate president and chairman of the Steering Committee for CHAMPS, which stands for Community Health and Men's Promotion Summit, providing free health screenings to economically disadvantaged minorities, of which he is an expert in this field. I would love to present and introduce Dr. John Bonhomme.
Good afternoon, everyone. Thank you for your interest in this topic. My presentation entitled Addiction as a Brain Disorder, it's a very important title because people have thought of drug use as being primarily a moral failing or something of that nature, but people have thought of drug use and addiction as primarily a moral sort of failing or a character disorder, but actually there are documentable changes in the brain that take place with drug use, and I think that understanding that will lead to development of better treatments and a better understanding of how to deal with this problem. First of all, let's do a little solid defining of what addiction is. Addiction is defined by compulsion. It's defined as continued substance use in the face of adverse consequences. For instance, a person drinks a pint of gin, gets into a wreck, gets their license taken away. 2 days later, they're back on the road drunk again. The punishment had no deterrent effect. The key into understanding addiction is that the person's function deteriorates, but the substance use continues. This is very different from a person, let's say, who has a ruptured disc in their back and they take a pain medication and now they can function. That's not addiction because their function improved when they took the medication. Deteriorating function, inability to function, continued use in the face of adverse consequences is what defines addiction. To understand addiction, you also have to understand something about tolerance. The brain becomes resistant to substances that are taken. So generally speaking, a lot of medications, especially pain medications, opioid pain medications, require an increasing dose with time. It may plateau at a certain level, but a dose that a person had that was relieving their pain may work for a while, but it may not work after months on the same medication. It might need increasing doses. Some people mistake that for addiction. They say this patient keeps asking for more and more medicine. Well, it may be that they've taken it, their body's become used to it, and it doesn't work as well anymore. So you may have to go up on the medication or use something different. Withdrawal is a feature of addiction. Basically, it's the set of negative mental and physical events that happen when a person who has been habituated to the use of a drug suddenly discontinues it. And what type of withdrawal you have depends on the nature of the drug. Opiate withdrawal may be characterized by sweating, vomiting, nausea, diarrhea, anxiety, things like that. Cocaine withdrawal might be characterized by severe depression, extreme hunger, desire to sleep. The nature of the drug defines the nature of the withdrawal. Surprisingly, withdrawal is not the whole story of addiction. You can have somebody who's been in prison for 5 years, let's say a heroin addict, and the day they get out, they start using again, and they're way past any physical withdrawal. They're no longer having the nausea, the sweating, or anything of that nature. There's something else going on that defines addiction, in addition to the withdrawal. There's also a phenomenon that we physicians have to be very careful of called pseudo addiction. That's when a person behaves like an addict. They may go doctor shopping, they may buy medications off the street, but pseudo addiction is caused when the pain treatment is not adequate to address the severity of the pain. A person may be driven even to illegal acts to obtain drugs and things of that nature, not because they are addicted, but because their pain is inadequately treated. And the distinction here is that if you manage the pain correctly, the drug-seeking behavior stops. You may have to use an additional thing, maybe a different medication, maybe a non-drug modality like epidural injections or something of that nature. But as soon as their pain is managed, they don't want the drug anymore. One thing that's important to consider in understanding addiction is route of administration, because when I started out with drug treatment, heroin addiction was synonymous with needle use, the junkie with the tracks up and down their arms. But now we have so much opiates on the street. The heroin has become much purer. Now we have OxyContin, we have fentanyl, we have all types of Vicodin, all types of opiates on the street. The supply is so plentiful, people don't always feel compelled to use needles. That's a good thing for one reason, but the fact is that you're not going to spread as much disease as easily without people sharing dirty needles. But the bad part of it is that it's easier to induce people to try drugs when a needle's not involved. If you go to a party and you got a needle full of something, say, let's get high, and not too many people are going to take you up. But if you say, let's smoke it, or let's eat it, or let's snort it, more people will try that. And smoking is actually the most addictive pathway to take a drug, because if you snort a drug, not that much gets into your system because the nasal passages don't have that much surface area, and it takes a long time. It takes 30 to 120 seconds before you feel it. If you inject a drug in your arm, it'll go into the right side of the heart, out into the lungs, up into the left side of the heart, and then up into the brain. That takes about 18 seconds. If you smoke a drug, your lungs have a surface area that if they were unfolded, it would be the size of a tennis court. Okay. Again, smoking is actually the most addictive pathway, because if a drug is smoked, it goes into the lungs, the left heart, and the brain, which takes only 7 seconds. Again, we said if you snort a drug, 30 to 120 seconds to get an effect and a low blood level. If you shoot a drug, 18 seconds, because it has to go through the right heart, the lungs, and then the left heart to the brain. But if you smoke it, 7 seconds. Now, if you were training a dog with food rewards, which would be most effective? If you give the food in 7 seconds, in 18 seconds, or in 120 seconds. The faster the consequence, the greater the effect on learning in the brain. And the other problem is that smoking is socially acceptable. Anytime that I hear a drug of any type become smokable, I'm very concerned, because more people will try it, and it actually leads to addiction very quickly. That's why it's so hard to stop tobacco. Okay. How does the brain work? Okay, this is a picture of a synapse, 2 nerve cells talking to each other. What happens is that the one called the axon dumps chemicals on the dendrite, which is the receptor, and then they pump back into the axon. That's the way that nerve cells communicate with each other. They communicate chemically. And to understand addiction, you have to understand something about this process. Neurotransmitters are the chemicals that they use, and they go across synaptic gaps. The way the drugs work is that they modify the effect of neurotransmitters. They may increase them, decrease them, block them, mimic them, or modify them in other ways. Some of the neurotransmitter functions, no need to know all these, but I want you to focus on dopamine, norepinephrine in particular. Those are the things that they do. Acetylcholine is associated with thought and movement. A lot of the drugs that they use to treat Alzheimer's, Aricept and Namenda, they work on acetylcholine. Dopamine has to do with pleasure and motion. When people have Parkinson's disease, their bodies are very stiff. That's the dopamine system. But also, dopamine is involved with pleasure. Serotonin, the serotonin reuptake inhibitors like Prozac, act, the antidepressants. They work through serotonin. Norepinephrine is your alertness, your call to action. That's important with opioids. Glutamate is the brain's accelerator pedal. Gamma-aminobutyric acid, or GABA for short, is the brake pedal. And endorphins and enkephalins, the dynorphins, are the brain's natural painkillers. Your brain makes substances like opioids, or opioids are like the substances that your brain makes, depending on what order you want to put it in. But that's the mechanism of opioids, okay? The way that addiction works is that by altering neurotransmitters' functions, they hijack the brain's reward system. They take over the same processes that govern our natural drives for food, water, sex. They get taken over. Addicts can reach a point where they no longer derive pleasure from natural means anymore. They may be able to enjoy only the drug, or they may not even enjoy the drug. They may have to use it just to feel normal. They can get that extreme. A heroin addict told me, when you get real strung out, you're not shooting to get high, you're shooting to keep straight, just to feel normal. Opioids have actions, excuse me, like morphine. They're natural opioids that are found in the opium poppy, morphine, codeine, thebane. They are synthetically altered derivatives of the natural opiates. Hydromorphone is dilaudid, hydrocodone, oxycodone, oxymorphone. Heroin is diacetylmorphine. It's just modified morphine. It gets into the brain more quickly. There are synthetic opioids: fentanyl, methadone, tramadol, propoxyphene. Fentanyl scares me the most because that can be made in illicit labs, and it's much, much more powerful than morphine. I think fentanyl is something like 80 to 100 times more powerful than morphine, and some of its analogs are even stronger than that. So when you hear some of the opioid deaths that we've been seeing, it's been somebody sold heroin, but it actually contained fentanyl, and even seasoned drug addicts can die from shooting that, or from using that. Sometimes they're making pills that look like OxyContin, but they're actually fentanyl, and it's much too strong. This is a very dangerous drug, and it doesn't need to be imported. They can make it, okay? To understand how opiates work, look at the diagram, endorphin. That's our natural brain painkiller. Look at the area in the rectangle, and look at the area in morphine. You see how the brain can mistake one for the other? You know, they look so much alike. They look so much alike, and they work on the same receptor. They're hardly different chemically. So the basic issue is that opioids are basically chemical imposters that act like the endorphins, like our natural painkillers. Overdose occurs when the person takes a dose with the physical condition that they can't handle it. A lot of the time, it's a drug interaction. The class of drugs, benzodiazepines like Xanax, Valium, those drugs are very dangerous to mix with opioids because they both suppress respiration. And when you put them together, a person might be able to handle a dose of one or a dose of the other. You put them together, it can prove fatal. Alcohol can also be fatal when mixed with opiates. Sometimes a person has a health condition like chronic lung disease. They have trouble breathing in the first place, and you give them an opiate, and opiates suppress breathing. They can't handle as much as a healthy person would. And so when overdose, the person can't be awakened, pupils can become small, skin becomes moist, bluish in color, breathing slows down, and death may occur, usually because of respiratory depression, meaning that they're not breathing anymore. Okay, we're going to get into some neuroanatomy. Don't worry about these names. They're not all that scary, but it's just to let you know what's happening when a person takes an opiate. The area is the ventral tegmental area, just the VTA for short, and the nucleus accumbens, or NA for short. When a person takes opioid stimulation of the VTA causes it to release dopamine, the pleasure chemical, in the nucleus accumbens. And then the person may get a euphoric recall that leads to the drug craving. But then what happens with repeated exposure, the brain becomes resistant. So you need increasing doses of opioids to get the same effect. The tolerance occurs because the brain cells become less sensitive, so you need to take more and more to release that. Then it becomes without the opioids, the brain doesn't release enough dopamine, and the person can't enjoy normal activities. The fancy psychiatric word is anhedonia, that they can't feel pleasure anymore without the opiate. So when a person becomes too habituated to the use of opioids, they can't enjoy normal activities. The locus ceruleus, now that's a fancy name. Locus means spot, and ceruleus means blue. So locus ceruleus just means the blue spot. That's an area in the brain that releases noradrenaline. Noradrenaline causes your alertness and your breathing. When you see a person who's high on opiates, you see that their alertness is down, they may be nodding and stuff like that. They're not getting enough adrenaline activity, and their breathing slows down. But then with repeated exposure, the locus ceruleus becomes resistant to the opioid too. It increases its output of noradrenaline. So then now when you don't have the opiate, the person has jitters. They're jittery because they got too much adrenaline activity in their brain. They're having anxiety, they're having muscle cramps, they're having the withdrawal syndrome. If you took a needle, an electrode, and put it in the locus ceruleus of a person who never used opiates, and you stimulate it electrically, they'll have the opioid withdrawal syndrome. They'll be sweating, their nerves will be jangling, they'll be vomiting, they'll have diarrhea and things like that. So what basically happens is that with addiction is that as the brain gets used to the drugs, the brain reaches a point where it needs the drugs just to get back to normal. It's not releasing enough dopamine, so they can't feel good. It's releasing too much adrenaline, so they're feeling jittery and anxious. And that's the reason why addicts seem so crazy. You know, why would you use a dirty needle knowing that you might get HIV or hepatitis or something of that nature? Because they're driven to. They can't feel good. They feel terrible. You look at a person in an opiate withdrawal, you say, it looks like a bad case of the flu. Actually, it feels a lot worse than that. So this model, the basic idea, these researchers said that there's a basic biological setting of the way that your brain works. It releases a certain amount of dopamine so you can feel normal. It releases a certain amount of noradrenaline so that you can be alert and so that you can breathe normally. But what happens when the person takes opioids for a prolonged period of time, their brain doesn't release enough dopamine without the opiate, and it releases too much adrenaline without the opiate. So then the person needs the opiate. That's when the addiction actually occurs. The set points of the brain change. Now, the congressman was dead right when he said, you know, don't take opiates for that long. Last year, my first time I had a tooth extracted. It was a wisdom tooth. They gave me 20 OxyContins. I took 3 of them. I won't stay on that stuff more than a few days. I just won't, because I've seen too many people get on it and can't get off. So by changing the set points of the brain so that the opiate is required to maintain normal levels of dopamine and noradrenaline, that's the reason why the person is addicted. So addiction needs to be regarded as a brain disease, not a moral failing. Now, when people are put on opiates, if they're taken off gradually, a little bit at a time, a lot of them can get back to normal if they haven't used too much for too long. If a person's been using opiates for a year, and I'll tell them, you know, we'll take 6 months and we'll gradually get you off, give you a methadone dose or buprenorphine, and slowly bring you off. A lot of people can get off. When they've been using 10 or 20 years, it's a lot more iffy. If they have a chronic pain problem, then it's much more difficult because they have to face the pain in addition to the withdrawal. And that's where it connects with the workplace. When we talked about men in the workplace, 93% of workplace deaths are men. And those deaths represent only a tiny fraction of the injuries. So I spoke to a man who was a laborer all his life. He asked why his hand hurt him so much. You could have struck a match in it. You know, they have arthritis, they have all kind of problems, they have back injuries. A lot of the patients that I've seen, I was amazed when I went into methadone treatment that a lot of the people that were coming there, they didn't get addicted because they went to parties and got high. They got addicted because they got hurt on the job. One guy fell 50 feet onto concrete and smashed half his body. You know, some people were in car accidents. Some people had a cancerous tumor removed and they were in chronic pain. You know, the fact is that a lot of people who become addicted to these drugs are not people who are trying to use illicit drugs, at least not initially. They just got hurt. So the pain management, doctors need to be more educated about how to use these drugs short term and how to taper them, you know, to get people off. Don't put a person on opiates for 6 months and then suddenly cut them off. They'll be climbing the walls because their brains have readjusted to too little dopamine and too much adrenaline. That'll make them really miserable because the set point has changed. Cocaine also acts by, I know the time is getting short, so I'm going to run through these. Cocaine also works through dopamine. All drugs of addiction appear to work through the dopamine pathway, the reward pathway of the brain. So cocaine works by blocking the reuptake pumps, so the dopamine that's released to the other cell doesn't go back. It just stays there, but then eventually becomes depleted, and the person gets depressed because they can't feel good. Amphetamines, the same, pretty much the same thing. Amphetamines worry me because the chemical structure is so simple, you know, that can be made from chemicals that don't need to be imported. Amphetamines, ecstasy, cocaine, they're all stimulants, cause the same basic problems. Depression, sleep problems, drug craving, paranoia, can cause psychosis, muscle tension, heart rate and blood pressure increases, brain damage. When they put people on methamphetamine, people for 2 weeks, it took 6 months for their brain scans to start to come back to normal and 2 years for them to recover fully. So these drugs can quickly cause changes in the brain that lead to addiction. Marijuana, I bring that up because it's probably the most common drug, illicit drug that's illicit in most parts of the country, but it does have medical uses. Personally, I'm a little leery about legalizing its recreational use because I'm worried about driving under the influence. You know, it's a lot harder to detect marijuana. If you take some marijuana and some alcohol, they're synergistic, so your blood level of alcohol may not be over the legal limit, but you may still be impaired. Okay, the self-medication hypothesis. Some people believe that, that people are predisposed to addiction because they have emotional, physical disorders. The drug of choice may be related to what the underlying disorder is. Like, for instance, people who have anxiety, they tend to like the downers. They like the alcohol, they like the heroin, they like the Xanax because it calms them down. People with depression tend to like the stimulants, like the cocaine and the amphetamine, because if they got low energy, they get a big blast of energy. It's only brief, but they feel, you know, energized and that type of thing. So the underlying an underlying psychiatric problem can predispose to drug use and subsequent addiction. Medications for opioid treatment. Methadone stimulates the opioid receptors. Naltrexone blocks the receptors. Buprenorphine is both an agonist and an antagonist. There's political opposition sometimes to using drugs like methadone because they say, well, methadone is an opiate. If you give that to a heroin addict, isn't that like giving gin to an alcoholic? And my response is, a turtle and a cheetah are both four-legged animals. Do they behave alike? You know, the point is that methadone is very slow. It gets in your system slowly so you don't get high. It comes out slowly so you don't get withdrawal. So the point is that methadone, yes, it's an opiate, but it doesn't behave like the opiates of abuse. So that's the difference between them. The way methadone was discovered was that when they were trying in the 1960s to help heroin addicts, they tried all kinds of drugs and they couldn't help them. And when they tried the methadone, one of the patients told a psychiatrist, Dr. Marie Niswander, I used to like to paint and I'm thinking of getting back to it. And she was shocked because she never heard them talk about anything but drugs. And they were showing outside interest. And they realized that the methadone kept them not high and not in withdrawal. When it was dosed properly, it kept them at an even keel. So that's the reason why it worked. Now, some people can come off of methadone gradually, but no, the drugs like methadone and buprenorphine, they're not like the opiates of abuse. They're long-lasting, and they don't promote abuse the way that the others do. We need to be mindful of dual diagnosis, that a person can use drugs because of an underlying psychiatric problem. According to the American Medical Association, JAMA, 37% of alcohol abusers and 53% of drug abusers have at least one serious mental illness. Sometimes you have to treat both. You have to say, is this person using drugs because they have depression, because they're schizophrenic, because something else is going on with them. You have to look at that as well as just the drug problem. I'm bringing this up, I'm going to run through it briefly, only because I want people to be mindful, as I learned and in my work as an addiction physician, that addiction doesn't just come by itself. It comes with other diseases. HIV, needle use can cause HIV to spread explosively. In the Ukraine, there were no HIV cases among injection drug users in 1994, but 31 to 57% were HIV positive about 2 years later. So drug use, needle sharing, because it's a direct blood-to-blood communication, can cause HIV to spread explosively. Hepatitis C, most of that was transmitted by needles in the 1960s and 1970s, and that can lead to cirrhosis of the liver. And I had a patient like this next lady, liver cancer. And that's not pretty, I know, but that's what hepatitis C can cause. Tuberculosis has been increasing because of alcoholism and also because of HIV. HIV-positive people are very sensitive to tuberculosis. There are local needle effects, abscess, cellulitis, which is infection of the tissues, phlebitis, which is infection of the vein, endocarditis, which is lining of the heart. The Mexican mud heroin is very dirty, and it can cause disease even with sterile injecting equipment, and it can even cause botulism. Sexually transmitted disease, they tested 407 subjects in a drug treatment program. 62% had markers for sexually transmitted disease. So in drug treatment, we have to institute HIV, HIV and STD screening and treatment. And I think that's about it. I had to run through some things, but I hope that was informative. And if there are any questions, is it time for questions?
We're going to save questions for the end.
Okay,
So,
great.
thank you.